This is a Swan-Ganz catheter. So what it does is they either insert it through the groin, so it'll come up here and go in through the pulmonary circulation on the right side of the heart, right? So it'll sit there in the pulmonary artery. Or they'll filter it in through the neck or the subclavian vein. And it'll go into the right atrium. You'll notice at the end, the balloon's gone on the end of this. But with this syringe, the syringe will usually go a cc and a half. And this balloon will take a cc and a half of air. It'll open up the balloon. The balloon will take the path of least resistance and go through the atrium, past the tricuspid valve into the ventricle, and into the pulmonic valve into the pulmonary artery, and sit there.
Is that the same thing they use for like central lines and stuff like that?
Central lines means that it'll stop right there in the right
Okay.
atrium.
Okay.
So this one keeps going. It goes through the
Through.
atrium, the
Okay.
ventricle, and out into the pulmonary artery
Okay.
that you can imagine.
Yeah.
So how does that, I was watching the
Video?
on YouTube,
Good.
and it's just crazy how from the right ventricular
Yeah.
going up to the pulmonary artery.
Yeah.
That's a pretty sharp angle.
It
you
sure
know?
is. So if the balloon's inflated and you're inserting it, it's just following the
Just
blood
flows.
flow. It's
Just carry it.
because on the end of that, you can see where the balloon was, Kyle. You see it? So the balloon maybe gets to be about this big, and so if it's filled up in the heart, it just follows the flow. But it can cause, every once in a very great while, because of that loop, it'll loop around itself and tie itself up.
Oh, no way.
Yeah, and if it forms a knot in there, you're in big trouble. So this is a highly invasive catheter, and it can cause trouble if it does, you know. And if you're jamming it on the inside of the ventricle, it can cause arrhythmias.
Is that why they go from like the cath lab straight to ICU? Like they don't.
Usually, if they put in one, it's highly invasive. It's the thing that we have to remember too is that we can draw blood gas from that line. Okay, so from this port, so this isn't something that we just look at and say, yeah, that's pretty neat. We'll actually go up to this line on the PA distal. So notice that the yellow mark here. The yellow mark is a PA distal. This one comes from the distal tip of the catheter. So when we draw back blood, we're taking blood from the distal tip at the end of this thing. So there's also a pulse oximeter at the end of that thing. So it's measuring the saturation. We can take blood and put it into blood gas and find out what the PO2 is in the right side. Now the right side is deoxygenated blood, right, Truman? Deoxygenated blood, so the PO2 would be less. So if we know what the PO2 is when we send it out to the body, we draw blood gas through the PA distal and the distal tip of this catheter, which is what the body's taken out, we can compare what was there and what's in it when it comes back to the right side of the heart. We can look and see what oxygen consumption is. That's pretty powerful, right? So we work with this catheter, and we'll draw blood and put it in a machine and measure the PO2. And it tells us a great deal about mixed venous. Did you notice that they called it mixed venous particularly? Mixed venous PVO2. So in the arterial side, have you noticed the denotation? So here's the alveoli. This is on this side is the PVO2 and the PVCO2, and on this side PaO2, PaCO2. So once it goes past the alveoli, this is from the right-sided heart, and then this is when it comes back to the left side of the heart. So it goes to the right side of the heart, to the lungs back to the left side of the heart, left atrium. So we're looking at blood and circulation and oxygen consumption. So I tried to help us to make sense of the terms more than anything. And we'll try to answer your questions as we go through this. Everybody take a look at the video on, the YouTube video on how that catheter goes through. Would be helpful because it'll specify the kinds of waveform pressures, because what it's doing is when the heart contracts and it relaxes and it contracts and relaxes, it causes pressures on systole and diastole, and those pressures mean something. Hi, Hannah.
Hey.
Good work on the exam. Do you guys want to tell her the good news?
Best average. The best average.
Highest average in 25 years.
Oh, wow.
Good job.
Thank you.
That's right. It's the
Over any
It's just a reflection of the teacher, I know.
It's a group effort,
But you
though.
can tell I really am passionate about the subject. Maybe that's the reason, I don't know.
Makes a difference.
I think the subject matter and whether the teacher likes it makes a big difference. Okay. So when we float that catheter through, it takes the path of least resistance, and that the videos will show you once it gets into the up over the central venous pressure. So either the superior vena cava, or if it's coming up from the groin, the inferior vena cava. What's the pressure there? What's the pressure in the central venous system? What do you think, Karina? The catheter is sitting there just before it goes into the atrium, or just as it's coming up from the groin in the inferior vena cava. What's the pressure in the vascular system before it enters the right side of the heart?
Low.
Yeah, very, very low. In fact, nearly zero. Nearly zero. Because remember when I drew that picture about, here's the lungs. We've got right and left. Actually, let's do this in red, because the heart's red. Maybe what we should do, let's do half of it in blue, because the blue part is deoxygenated, and the other part in red, because the right side is deoxygenated, the left side is oxygenated. And if we cut that in fourths, let's see, the pulmonic valve, and then the pulmonary veins come back.
Oh, that's right.
Okay.
Yeah.
So when the heart comes through the superior vena cava and the inferior vena cava, blood pressure is very, very low, nearly zero, because when the muscles contract, they help to move blood up, right? And then the valves will catch it, and then the muscles will contract and move the blood up. So the blood pressure is very, very low in the right atrium, or the central venous pressure. And the text uses a range of about 0 to 8 millimeters of mercury. So it's very low, and it's dependent upon the vasomotor tone, and it's dependent upon the volume of blood in the vessel and how much the valves are pushing it up. So we don't really circulate it into the right side of the heart. We muscularly contract the blood volume up, and it essentially falls into the right atrium. So 0 to 8, and we call that CVP. So central venous pressure is the pressure before the blood gets to the right atrium. Yeah.
I had just had a question, because like if the blood's being pumped out of the left, doesn't that have like any like force?
It does, from the left side. So from the left side, remember last time we talked about mean blood pressure, right?
Mm-hmm.
So the 2 times systole, is that right?
I think so, or
Or is it diastolic? It's diastolic. Diastolic pressure. 2 times diastole
yeah, plus
plus
systole.
systole divided by 3, and this is the mean. So 1 diastole is 80, so that's 160 plus 120 is 280. Divided by 3 is 93. So when the blood comes out here, we've got a mean blood pressure of 93 millimeters of mercury. So there's some pressure, and it does formulate a flow to the blood such that when it comes around to the aorta, there's an average, 93, and then it goes to 83, and then it goes to 73, and then it goes to 53. And down here in the toe and out in the periphery, it's 43. And it goes to the peripheral capillaries, it's 33. And then down, as far away from the heart as it can get, it might be around 20.
Okay, so eventually it just doesn't.
Yeah, you lose your blood pressure. And remember, in chapter 5, we suggested that blood in the arterioles are, the pressure or the resistance is a function of the vasomotor tone and the
That's right.
and they're called resistance vessels because they have the ability to constrict and relax depending upon what that pressure is and how much volume there is. So resistance vessels. However, when you get down into the peripheral capillaries, when it gives its oxygen up to the tissues are creating ATP, and then CO2 as a result of phosphorylation, the use of oxygen and sugar that creates ATP and energy in glycolysis, then we create CO2 from respiration, and we liberate that back to the vessels. But we don't have as much vasomotor tone. So these are called resistance vessels. And these over here, before they come up to the inferior vena cava, are called capacitance vessels. And in capacitance vessels, we maintain about 60% of the cardiac output. So of all the blood that's going around, 60% at any one time is in the capacitance vessels, which has less vasomotor tone. It has less blood pressure, and we have to rely on muscular effort, particularly in the legs, to move it up these vessels to get back up to the right side of the heart. So it's essentially zero,
Okay.
or at least very, very low pressure, 0 to 8 CVP. So we lose it as it comes around, and we move it back up to the heart through muscular effort.
I was working out yesterday and I kept on thinking about that. I was doing these like
Spending way too much time on A and B. And I like it. That's good. That's good. So CVP, we actually lose our blood pressure in these capacitance vessels. It's very, very low resistance. So we have to rely on how we exercise to move blood back up to the heart. So very, very low pressure. Once that blood and the volume of blood, now the cardiac output is equal to the stroke volume times the heart rate, right? And that if your heart rate is 70 and your stroke volume is 70 milliliters, so 70 beats per minute, your heart beats 70 beats per minute times 70 milliliters, that gives you a cardiac output of 4.9 liters. So it's just 7 times 7. 4.9 liters. So when we say our cardiac output is roughly about 5, we're making a big assumption that all of us have a heart rate of 70 and a stroke volume of 70 milliliters. Okay. So and 60% of that volume is kept in the deep veins in the legs, in capacitance vessels. Which is why pulmonary embolism, have we talked about pulmonary embolism at all? A little bit. That's why patients that are flat in bed that don't get up and walk around are at risk for pulmonary embolism. It's probably the most important pathology for surgical patients. 60% of patients that die in the hospital die because of pulmonary embolism. So
really?
How many patients did you see yesterday, or was it yesterday or Monday, with TED Hose?
All
All of them.
Almost all, yes, you're exactly right, because it's the most preventable pathology. So they're all on
Let's see,
some kind of sequential TED or TED hose or something that squeeze. Have you seen the ones that squeeze their feet?
Yeah.
They just put a little wrap on the arch of their feet, and that pushes pulses of blood up into the deep veins.
Ours had the leg ones.
All the way up?
The calves.
The calves.
And it would like beep if they got unhooked.
Yeah. So it's the most preventable pathology. That's why they're all on TED hose. If they're not ambulatory, put them on TED hose to prevent pulmonary embolism, because 60% of your blood volume is kept in your deep veins. Okay, makes sense a little bit of why they would be, or why we encourage so much patients to get up and move around and walk, because it prevents a lot of complications from post-surgical patients. 60% that die in the hospital die because of pulmonary embolism in large metropolitan hospitals.
Yeah, I remember like 4 years ago, I did a shadow in like a hospital, and they did an open heart surgery, and there was one that was a pulmonary embolism that got like, that reached the heart,
Yeah,
and they pulled it out. I'm like, wow.
yeah, it's pretty amazing. Open heart surgeries, did anybody see one this week?
Hey, what?
Did anybody see an open heart surgery or recovered a patient? You will. They are usually standing within 24 hours. They'll stand them at the bedside within 24 hours. So when I started in 1981, they were in bed for 3 or 4 days. They didn't touch them for 3 or 4 days, just letting them recover. And in retrospect, I wonder how many PEs we had because we didn't get them up and move them. So even patients on ventilators, lovingly we call it dragulation. We'll put a therapist under each arm, or a physical therapist or a CNA under each arm, and we'll literally drag them down the hall while the respiratory therapist bags them if they're still intubated. We'll just get them up and move them at all cost to get them to move. And it's called dragulation. It's not ambulation, it's dragulation. But the whole point is to get them up and to use their muscles and do something to prevent blood clots. And psychologically it helps. There are multiple benefits. You can find research articles that attest to the benefit of quick ambulation after any kind of surgery. Okay, so central venous pressure, CVP, is the pressure at the central part of the heart. What was the one you were asking about? A central line. So a central line will essentially, so here's the superior vena cava. A central line will sit right there. And you'll get a chest x-ray, and you'll see the tip of the catheter is right there just before it enters the atrium. So a central line is usually a triple lumen catheter that sits in the superior vena cava. It'll stay there. The purpose of a central line is to give quick central access to medications. Or they'll sometimes use PICC lines that go about the same area, but PICC lines to give antibiotics or things like that goes into the central circulation. So a central line, a PICC line, those are all centrally located to get it immediately into the circulation. That's the purpose of a central line or a PICC line. So CVP on this catheter, where did the catheter get to? On this catheter, there is, so it'll, usually what we'll see it sticking out of someone's neck, and you'll have all these lines, all these catheters, just kind of sticking out on the bed. And this catheter will be inserted into the patient's chest like this. So the markings on here are at certain intervals. This one, there's a little opening right there, and there's a little opening right there. I don't know if you can see those looks like it's at 10 centimeters and 15 centimeters. So the purpose of those markings is that this one at 15 centimeters should open up in the right atrium, so you can measure CVP. So all of these monitor, all of these catheters connect to holes and openings in the Swan-Ganz, that you can connect these to a pressure manometer. And that manometer then reads out the pressure at these different ports. Well, if you've got an opening in the right atrium and it measures the pressure, it should be 0 to 8. 10 centimeters away in the ventricle, you should be able to read what the left or what the right ventricular pressure is on systole and diastole. So it'll be different than the pressure in the atrium. And we can hook these all up to manometers and measure and read out the pressure. So this one goes to the end of the balloon. Usually once it's floated into place, we'll deflate the balloon and let it just sit there. But there's I'll talk about it in a minute, there's a pressure that we can get when we wedge that balloon. This one goes to the pulse oximeter, it measures saturation, and this one goes to a cardiac output manometer that we can measure, we can estimate what cardiac output is. So we have multiple functions, but these other ones are ports that we can give medications, another port that we can draw blood gas from, and this one is from the PA proximal, which would be the CVP port. So we can take samples out and measure it. Okay.
That's crazy.
So once this catheter then gets into the right atrium, we'll stick it in through either the subclavian below the clavicle, or it'll come in through the internal jugular in the neck. What's a complication of inserting a catheter like this if we go in underneath the clavicle? What do you think could possibly happen? What's a complication?
I guess it could pinch the line or something if they like lay on it.
Yeah. So if we have to poke a needle just up underneath the clavicle, we're trying to get in through the vein there.
The angles.
What's underneath the vessel and underneath the clavicle if you
Nerve
go
and
too
artery.
far?
The arteries.
Nerve.
How about the parietal pleura? So it's possible, and it's I'm not going to say it's common. It happens maybe in 1%. So maybe 1 in 100 will puncture the parietal pleura. So if you puncture the parietal pleura, that goes into the lung basically, right? And then you've got a pneumo. So a pneumothorax can be a complication of putting this in the subclavian vein. That's usually why they'll go in through the internal jugular. So, or through the groin too. It's a long enough catheter it can do it, but usually we go in through the superior part of the chest. So once it gets into the central circulation, we inflate the balloon 1.5 cc. So just 1.5 cc. That goes into the red port, and it says balloon on it. So then you insert that, the balloon inflates. Now it's going to take the path of least resistance into the right atrium. Once it gets to the right atrium, the blood pressure inside of there what's the blood pressure relative to CVP in the right atrium? This comes up through there. So I'm going to stick that up there in his neck, and I'm going to start to insert it.
You said right atrium?
It's the same, right?
So yeah, so right atrial pressure,
It's still 0 to 8.
right, so CVP 0 to 8 millimeters of mercury. So the blood volume in the right atrium, the tricuspid valve is here. What happens to the blood in an upright lung or an upright heart when the atria doesn't contract per se, it kind of folds over itself. So the preload, the amount of volume in the right atrium, essentially just falls into the ventricle, okay? Nothing resists it or holds it up because the tricuspid valve is kind of moved in on itself anyway. So whatever volume is in the atria falls to the ventricle. So this is 0 to 8. Once it gets into the ventricle, however, we're gonna advance the catheter. See if I can get this to work. So now we're going to advance the catheter down into the ventricle. And sometimes the normal curvature of the tube will help, but the balloon, the fact that it's flow directed, is what helps more than anything. So it goes through the tricuspid valve, it's now in the ventricle. What happens when the ventricle contracts? The tricuspid valve closes because of the way, so when the ventricle contracts, the tricuspid valve closes and it pushes blood through the pulmonic valve. Okay. So on systole, what's the pressure generated in the right atrium? Yeah, it goes up to about 25 millimeters of mercury. So 25, Jimmy, over 0. Because when the ventricle relaxes, then the blood from the top is just kind of dropped into the bottom. So essentially, 25 on contraction, 0 on relaxation. Or 25 over systole, 0 over diastole. So right ventricular pressure ventricular, RV is equal to 25 over 0. Because there's no resistance in the right ventricle. And what do we know about the muscle of the right ventricle compared to the muscle of the left ventricle? Yeah, smaller because it's a much lower pressure it's exposed to. Hannah, go ahead here.
Sorry, do we need to have these numbers memorized?
For now, no, but in the
Eventually.
future, this will become second nature.
Okay.
You
Right.
will develop to where it is. And if you notice, last chapter we talked about pulmonary vascular resistance and systemic vascular resistance. Well, that's just the blood pressure. And the pulmonary vascular resistance is a result of the blood pressure of these measurements.
Okay.
So, on Canvas, was there a video that looked at the monitor of these pressures too, the waveform that it creates as you're pushing this through did you see that video?
I just YouTubed it because I was curious. I
Oh,
didn't look
okay.
at Canvas. Yeah.
Check on Canvas. We'll do it at the break, and we'll see which videos are available. But what we'll do, and Hannah, this is particularly important, is that we recognize that these pressures are generating a waveform on the monitor. So we can visually see where the catheter is by what the waveform looks like. And the higher the waveform, the higher the pressure. And so it's visually important to know what the waveform looks like, but behind that waveform are these pressures.
Okay.
So it'll become evident, I think. And
Okay.
I'll make sure, for instance, the bottom of page 484. So when the catheter is sitting in the right atrium, it's responsible for 0 over 8 millimeters of mercury. Notice what the waveform looks like on the bottom of that page. Very low pressure, pressure on the left-hand side, and time over the bottom. So on contraction and relaxation, we have very low pressures, down less than 10 millimeters of mercury. Make sense? Because the atria don't really contract, they fold over themselves, so you don't really have contraction and relaxation and contraction and relaxation. Low pressure, 0 to maybe 8 at the most. Notice what happens when it gets past the tricuspid valve. Now the tip of the catheter is in the right ventricle. The right ventricular pressure is 25 over 0. So on systole, the pressure goes up and it's measured at 25 millimeters of mercury. On diastole, the pressure goes down to nearly 0. And the diagram on 484 After CVP, you can see that the pressure is going up, pressure goes down. So you have a visual representation of the pressure of 25 over 0, over 25 over 0. That's systole and diastole. So that visual representation of that waveform tells you that's in the right ventricle if the pressure is 25 over 0. Now, you can see it doesn't always go right down to 0. Theoretically, it should, but yeah, it's within 2 or 3 usually millimeters of mercury. So, in the next segment then, what happens when the pressure goes to 25 and now it's going down to around 12? What's that a visual representation of where that catheter is in the heart? Yeah. So now it's gone past this pulmonic valve. It's gone all the way past this pulmonic valve, and it's sitting in the pulmonary artery. One more piece of tape. So it's taken the path of least resistance. It's once the blood goes past the pulmonic valve opens on systole, so blood can go through. On diastole, the pulmonic valve closes. Now there's back pressure in the pulmonary system. Okay, and it's back pressure evidenced by the diagram on the bottom of 484. When the blood pressure goes up to 25 and it comes down to about 12. So what that means is that the pulmonic valve has closed, and there's back pressure now in the pulmonary system. That's pulmonary vascular resistance, 25 over 12. So it's creating a blood pressure in the pulmonary artery because of the closure of the pulmonic valve, and now you've got all the blood that's going through the right lung and the left lung as resistance. Okay, so recruitment distension can influence that, what happens to blood flow in the lungs. But the reason that there's a high pressure and a low pressure, 25 over 12, is because it's encountering resistance through the pulmonary system. And you're measuring that not only on the waveform, but also by what you see on the monitor that measures that pressure. So we can tell if this catheter is in the pulmonary artery by the waveform analysis, representing pulmonary pressure on systole of 25 and on diastole at 12. It means that the pulmonic valve has closed and now that there's resistance of blood flow throughout all of the lung fields. Okay. Well, notice that there's a bit of a diagram beyond the pulmonary artery. So if we keep inserting this catheter to the end of move this over so you can see it. So we keep inserting the catheter. The balloon's still inflated. Eventually we come to a place where this catheter is occluded in what I've drawn is the balloon there. So the balloon occludes this vessel, and from this point on, there's no more blood flow. So if I occlude the opening to this blood vessel, I've inserted the balloon far enough that eventually in the lungs, the airways become smaller and smaller and smaller, right? Well, the blood vessels also become smaller and smaller and smaller, and eventually the balloon is going to occlude the vascular wall of that blood vessel. Once it occludes the vascular wall of that blood vessel, there's no flow. So you can see that if we inflate the balloon and stick it into the pulmonary artery such that there's no flow distal to the tip of that catheter, beyond that catheter, if there's no flow, then there's no resistance. And if there's no flow and then there's no resistance, then the blood pressure here at the distal tip of that catheter is the same throughout all of this vasculature back to and representative of LAP, left atrial pressure. So you have to make some assumptions that at the tip of this catheter, if you're measuring if you're measuring no flow beyond the tip of the catheter, if there's no flow, there's no resistance. If there's no resistance, then the pressure right here is the same as right here, is the same as here, is the same as here, is the same as here, and same as here, same as here, leading back to there. So it functions on the assumption that if there's no flow, there's no resistance, and if there's no resistance, then the pressure at the tip of the catheter is the same, leading to the left atrium, through all the miles of vasculature in the pulmonary system, okay? So the balloon is inflated, there's no flow distal to the balloon. If there's no flow, there's zero resistance, and if there's no resistance, then we can make assumptions about what the pressure is back in the left atrium. So this is called pulmonary capillary wedge pressure, because the tip of that catheter is wedged into a position that prevents blood flow behind it. Okay. So pulmonary capillary wedge pressure should be about 8 to 12. What does Desjardins say?
4 to 12.
4 to 12. 4 is a little low for me.
You should.
Yeah, it's around 8, it's not 4.
Okay, what does Lindsay Jones say? So here you'll find some clinical differences. We can express what we think normals are, but normals are normal for almost every individual. We can come up with ranges that we expect, but in the end, what you see in practice every day might be a little bit different than what a textbook says, or what a professor says, or what they do clinically practice at the bedside. So around 4 is low for me, but 8's a little better. 8 to 12 is a good range. I would focus on what Lindsay Jones says. Typically in practice, we don't see them much below 6. If it's 6, we're worried. Because what does a pulmonary capillary wedge pressure of 6 mean? So notice we don't get a systolic pressure and a diastolic pressure in the pulmonary capillary wedge pressure. There's no systole and no diastole. Why not?
There's no flow, no resistance.
Yeah, and so if there's no flow, you're not getting what happens when the heart contracts and what happens when the heart relaxes. All you've got is volume inside of that vessel. So it's a singular volume. It's not a high or a low. It's what it is. So the wedge pressure is a single number, usually around 10. So a little lower than 10, a little higher than 10, that's okay. If it's a lot higher than 10, 14, 16, 18, that's pulmonary hypertension. If it's lower than 10, 2, 4, 6, that's pulmonary hypotension. Right? And it's relative to blood flow. Okay? Relative to blood flow. So if someone gets into an auto accident and loses 2 liters of blood, what do you think his pulmonary capillary wedge pressure would be? It would be low, absolutely. It would be low. So if we had that patient, we noticed that their wedge pressure was low, we gave them a liter of fluid, it comes up to 6, and that's survivable. So we can treat things if we know what the pressure is. The thing with a pulmonary artery catheter is that it's invasive, it's cause for concern because of infection. You know, if we're messing around with these ports out here, drawing blood, you know, we'll take off the cap on this one, roll it around in our hand, and stick it back on that thing. You know, we're introducing whatever was on our hand into that catheter, and then that gets into the patient's central circulation. So it's a place ripe for infection. That's why we wear gloves. And that's why when I take off the cap on one of those to draw a blood gas, I'll put it inside of like the syringe container. I'll put it right side up and set it down with purpose on top, so that when I take that back off and stick it back in, it hasn't touched anything. So if I take it off and put it in the sheets on the bed, and then it rolls around and I pick it back up off of the sheet and stick it back into the central catheter. Where's that infection going? Right to that patient's heart. So this is an invasive catheter that's ripe to introduce infection into the patient's central circulation. We have to be aware and knowledgeable about that. Let's see. So we treat patients based on what this central pressure is. We pay attention to what the CVP is, because the CVP is directly relative to preload, right? If the CVP is 0, you know, I could maybe give a liter of fluid and get it up to 3 or 4, and that's gonna directly improve my preload. So I can improve cardiac output if I know what to do with those numbers. So these numbers are diagnostic in that they tell me something about circulating volume in the right side of the heart and what's eventually going to go to the lungs. So that blood then gets to the lungs and exchanges gases and goes back to the left side. The left side tells us a little bit more with pulmonary capillary wedge pressure about left ventricular filling pressure. So I'm making an assumption what the pressure is in the left atrium and what's going to be relative to be circulated out through the left ventricle on systole, on contraction. Okay. So you have to recognize that systole and contraction are the same terms. They're synonymous. Relaxation and diastole are similar terms. Relaxations. So the heart contracts and relaxes. When we see it on an EKG, and I'll do this next semester, you'll watch on systole the blood pressure will go up 120 over 80. 80 is diastolic pressure. So the pressure of the circulating volume is also another pressure that we make sense of and diagnostically use to help to make decisions about how to care for a patient. These are usually critically ill patients. You know, a fairly routine post-op who may not have a Swan-Ganz catheter. These are patients that are critical in circulating volume that would have a flow-directed pulmonary artery catheter or a Swan-Ganz. So when that catheter is wedged, then it's called pulmonary capillary wedge pressure. 8 to 12 millimeters of mercury is about normal. Lindsay Jones and others may go a little bit lower, but that's associated, a lower wedge pressure is associated with low circulating volume. Okay. Let's see, I should probably define pulmonary artery pressure, or PAP, pulmonary artery pressure, usually 25 on systole over 12 millimeters of mercury. So we have an idea of what these pressures are and how they're generated and what they mean. Okay. It's represented by the diagram on the bottom of page 484, usually at the bedside when these are being inserted, and I think I included a couple videos on Canvas that shows the waveform when it's inserted in the right atrium, the right ventricle, and the pulmonary artery, and the wedge. So this last little bit is what the pressure is when it's wedged into the vessel.
Sorry, what's the third one down?
Pulmonary artery pressure.
PAP.
Oh, PAP. Oh.
Pulmonary artery pressure. And that has resistance because the pulmonic valve is closed. Now on systole, the pressure should be 25 millimeters. On diastole, because of resistance in the closure of that valve, it's 12 millimeters of mercury. So PAP is 25 over 12 on systole and diastole. Okay. Any questions with that part of it? Yeah. So hemodynamics is the study of the flow of blood, basically. So how we move blood through the heart. We move it through based upon volume. Volume is dependent upon what gets back to the heart. That's very low pressure, central venous pressure. Once blood goes from the central venous system into the right atrium, it stays fairly low at about 0. The atria folds over itself on systole, so we might create a little bit of a pressure, maybe over 6 millimeters of mercury. Once the atria fold over, the tricuspid valve opens, blood goes into the ventricle. On contraction, the tricuspid valve closes. It builds up pressure of 25 millimeters of mercury, pushes blood through the pulmonic valve. When the atria or the ventricle then relaxes on diastolic pressure, creates a pressure of 0 or near 0, and allows it to be filled from the blood above in the atria. Once blood goes into the pulmonary artery, it creates a back pressure because of the pulmonic valve closure. That back pressure of blood through the pulmonary system is reflected as resistance. That resistance is 25/12. Throughout the pulmonary circulatory system, we recognize and understand that the pulmonary resistance is a low resistance organ. It only requires partial pressures of 25 millimeters of mercury, whereas the systemic resistance, the blood that goes through the rest of the body, generates pressures of 120/80. So the heart has to generate 2 separate pressures, right-sided pulmonary pressures, left-sided systemic pressures. And those are under differing conditions. We still have to pump out the same amount of stroke volume per contraction, or blood would get backed up in one or the other system. And we can measure that if we recognize these pressures and where, in fact, I think probably around the first of the fall semester we'll have the author of Lindsay Jones, his name's Dennis Stanley. He'll come and do a lecture on hemodynamics specifically and how to tell where the problem is. You can tell if it's in the right-sided heart failure, if it's in left-sided heart failure, or if it's in the lungs, based upon where these pressures are located. So I realize this is the first introduction to hemodynamics. We're not going to get it the first time, but we'll start to make sense of it. And in subsequent classes, you'll see it in clinical. You'll make sense of these pressures, and over time, it'll make infinitely more sense. But this is kind of a new idea right now. We understand. So let's take a break from there, and we'll figure out where to go.